So our speaker is coming. He's just a little delayed, so if you guys could hang in, that'd be great. This is like social hour. Actually, this is Hope in the Morning. We're, we're hoping he's going to show up.
think it all works, I think. Yeah.
It's not showing up there yet.
Yeah, it should work, yeah.
Okay, good morning, everybody. I think we'll go ahead and get started. We're very fortunate to have Dr. Mahadevan from UCSF here this morning after a very stressful drive from the city. He made it. So Dr. Mahadevan went to medical school in India and then did his medical training in the UK, first in Belfast, Northern Ireland, and then at the Royal Brompton in London. He did a year of a specialized adult congenital heart disease interventional training in Toronto, which is sort of the epicenter for such things, and then spent his formative early years back in the UK working in Manchester at the Royal Infirmary and at the Royal Liverpool Children's Hospital before being lured away to UCSF in 2014. And he came to UCSF and helped start up their TAVR program and has risen up through the ranks there since. He's now the Director of Interventional Cardiology and the Director of the Adult and Congenital Structural Heart Program. He also holds the William Parmley Endowed Chair within the Division of Cardiology. He's published widely in the topics of structural heart interventions and all things related to putting valves in and plugging holes, and really looking forward to his presentation this morning on adult congenital heart disease. So welcome, Dr. Mahadevan.
Yeah, thank you so much, John, and good morning, everyone, and my apologies for running a bit late. Despite my best efforts, the traffic did kind of scupper my efforts, but I'm looking forward to a good session this morning. So these are my conflicts of interest, and so adult congenital heart disease is a growing population. As you all know, the incidence worldwide is around 0.6 to 0.9%, per 100 live births. And it is higher in some areas. For example, if you live in high altitude, if you go to Tibet or Machu Picchu, the incidence of congenital heart disease tends to be higher, primarily driven by patent ductus arteriosus and stuff, which are higher in high altitude. And it's true in places like Tibet too. But whereas in most other parts of the world, it's somewhere around this percent. And now we are in a situation where about 80% of all kids born with a congenital heart condition will become adults. That number is increasing by the day. Probably the only big condition which ever we now advise termination, or if at all they want to consider termination, is hypoplastic left heart syndrome, which still, despite the best efforts, when they reach their 20s, they run into trouble. But almost every other condition, the patient can survive and really relatively normal lives. And now there are more adults with congenital heart disease than children in the Western world, and that's probably rapidly becoming true in many of the developing countries too. So this was a study done by Grutman et al. From Toronto a while ago, looking at survival for patients with some of the complex congenital heart conditions. Mind you, these are not the simple ones. These are the complex ones. This is the atrial switch operation, the mustard procedure. As you can see, there is an attrition rate, slowly as the years go by, and at 50 years, only about 50% of them alive following a mustard operation, which is not, unexpected given that the right ventricle is a systemic ventricle. If you have a congenitally corrective transposition, which essentially is nature's own way of, double switching without any surgery, again, the attrition rates are largely, similar. And then the worst outcomes are for the Fontan operation, which is what we widely use when we only have one ventricle, which is working, as you can see. And then for repair tetralogies, you can see, this is the cyanotic condition, probably most scary to mom and dad, when a child is born and is blue. But actually, if you look at the survival curves, are excellent. And now I can tell you the oldest, tetralogy patient who was repaired, I have in my clinic whom I put a third pulmonic valve in, is now in his early 70s. So we're kind of extending the lifespan of these people more and more and more. So this is a paper which just came out in the Journal of American Heart Association, which Anu Agarwal, a former fellow, now my colleague, and I work together along with various other people looking at, what are the comorbidities among, the adult congenital heart disease population? Do they behave normally as like other adults, or that increased risk? And this was done using the IBM MarketScan commercial claims database over a 6-year period, and more than 40,000 patients were identified. And what we found was adults with congenital heart disease were nearly twice as likely to have a comorbidity than those without CHD. And looking at this, this was the primary lesions. I mean, if you look at this was the one, the top graph is for patients, aged between 18 to 40, and the bottom graphs are patients greater than 40 years of age. And this is a rough distribution of all the complex lesions. I mean, for example, transpositions is about 8.5%. And as you see, the commonest, one of the commonest survivors of complex congenital heart disease now is tetralogy of Fallot. I mean, if you had said this, 20, 30 years ago, people laughed at you. I mean, these guys are never going to survive, never going to be alive. But this is one of the commonest, cyanotic conditions which people survive. And then you have other simpler conditions like VSD and relatively simpler conditions like coarctations. And if you look at the older age group, again, it's the same thing. There is an attrition rate. But still, a lot of these patients with complex, heart conditions survive. And it's interesting, the common ventricle, that is, i.e., if you are born with a single ventricle and the hypoplastic left hearts, as you can see, pretty small numbers, only about 1% of them reaching to this age. And that is probably because, transplantation in these patients still is not quite as, active as it is in other subsets for a number of reasons. I mean, we can get into that, discussion later, maybe. So we do know that adult congenital heart disease is associated with comorbidities. And so what did we find? I mean, this is an age-stratified relative risk score for having comorbid conditions among patients with severe versus non-severe. So if you look at any comorbidity in severe congenital heart disease, around 30%. So around 1/3 of patients will have a congenital heart condition, and whereas in non-severe, it's lesser. And if you look at, other cardiovascular and non-cardiovascular, I mean, it's around 10%, in patients with severe CHD. And in non-severe CHD, it's kind of, other risk factors which take over. And any comorbidity, if you look at it, overall, i.e., assuming kidney, liver, et cetera, diabetes, it's all pretty more common in adults with congenital heart disease. So this has got a big implication for, non-congenital cardiologists to see these patients, because a lot of them do come to non-congenital clinics. It's very important to recognize, these patients are at higher risk for these conditions. And if you look at it, the relative risk for having individual comorbid conditions, and as you can imagine, congestive heart failure is the highest, as you can see here, and followed by other things like arrhythmias, which again is a very common congenital problem, and pulmonary circulation disorders, and hypertension, interestingly, was pretty common, more common than the population subset. And in the non-severe CHD, it was lesser, around 10%. But whereas if you look at it here, it was 19%, and hyperlipidemia and various other things are all the normal things. And non-cardiovascular, around 30% of them have chronic lung disease, and this is not surprising, because when you have congenital heart disease, you get 1 or 2 repeat surgeries, and you do a PFTs on all these patients. We all know they all have a restrictive lung defect. I mean, it is very common. I mean, it gets reported all the time, and it's part of the reason why their peak VO2s are not very good. And we do know congenital heart disease, in adults is a chronic heart failure syndrome, because there's a lot of data. My former boss from, Brompton has published a lot on this, Mike Getsoulis, which shows, the increase of BNP levels, decrease of peak VO2 levels. So we do know that, a lot of these patients with complex congenital heart disease have a chronic heart failure syndrome. And this is the lesion-specific prevalence risk for all lesions. And as you can see, I'm sorry about the small print here, but Eisenmenger syndrome came out on tops here, 32.2%, which is hardly surprising, because any cyanotic condition is always associated with multiple comorbidities. The liver dysfunction, the polycythemia creates, renal dysfunction. So it is very common, and as you can see, followed by the common ventricle of the hypoplastic left heart, in the second and third row. Again, if you have only a single ventricle functioning and you have a Fontan circulation, you're unlikely to do well. So these are kind of predictable patterns. So it is very important to recognize these, when we see patients in our general practice and see how we can treat them. Now, what I'm going to do is take a little bit of a deep dive into some of the specific, congenital heart conditions in adults, so that we can kind of, understand what the conditions are, which present in adults. So phallus tetralogy, for those of you forgotten from your medical textbooks, is 4 components. A ventricular septal defect, which is usually a pretty large one. Then you have pulmonary infundibular stenosis, which is the second component here. And, hypertrophy of the right ventricle is an accompaniment to that. And the fourth is overriding the aorta. The aorta straddles the interventricular septum and partly comes off from the right ventricle. For the cardiographers among you, if there's a 50% override, it's considered significant. significant. Anything less than a 50% override is usually, probably kind of the borderline spectrum. And as you can know, if it's nearly an 80% override, then it gets classified as a double outlet right ventricle. So now you can see how there's a whole spectrum of things, starting from an endocardial cushion defect of a VSD to a double outlet right ventricle. It is just the nature of abnormality, the degree of abnormality which happens, rather than, one specific gene, dictating whether tetralogy follows a convenient, beautiful, clinical, classification. It's a neat subset. It looks good. But actually, if you look at it embryologically, it is a spectrum of disorders, going from a simple VSD or an AVSD right all the way going down to a double outlet right ventricle and a single ventricle physiology. So how did they repair this? In the days gone by, this is what they used to do, although this is not done much commonly now. So the adult patients we see, a lot of them are this. They put a patch, to augment this infundibular stenosis and get rid of it. And then they, close the VSD. And essentially, the way the VSD is closed is you put a patch to redirect the aorta back into the left ventricle. You don't shift it. So essentially, the patch redirects the aorta into the left ventricle. Then you have the VSD closed and, the infundibular resected. So what happens for Infollows repair? This was a huge series done in Great Ormond Street in London. More than 1,085 patients undergoing TOF repair over 5 decades, from 69 to 2009, and 152 total deaths, of which 100 happened in the first year post-op. But this, you got to remember, it's a historical series when death rates were much higher. Probably now, for any good center, major center, the primary fallow repair mortality would be around 1 to 2%, no higher than that. So if you look at it, 189 patients eventually ended up needing a pulmonary valve replacement, which is the commonest thing which happens in these patients. And in patients who are greater than 35 years of age with no pulmonary valve replacement, they had mild RVOT obstruction. So if the surgeon did a very good job of getting rid of the RVOT obstruction, you ended up with pulmonary regurgitation. The surgeon did a slightly lousy job of leaving you with mild RVOT. Actually, it was protective. These are all things which you have learned. And one of the things, was that now what you do have is you have transatrial repairs. So you don't have ventriculotomies, which reduces the risk of VT and so on and so forth. So this was the series they look at. Sorry, this doesn't project very well. So if you look at it, the number of patients needing a PVR is almost rising up to 30% in the 4th decade of life. So this is the commonest operation, the commonest presentation you're going to get in a repair tetralogy is pulmonary valve regurgitation. Which kind of leads on, so what do we do now? Surgical PVR used to be the standard, but then you come to any adult congenital conference, we have one every Friday. There's one running this Friday morning. And, we don't use surgical PVR as a first standard unless there is no other option. Transcatheter is now considered first line in most patients. The Melody and the SAPIEN XT valve, which is the Medtronic and the Edwards valve, have FDA approval for use. The SAPIEN can be used in large annulus patients. A stent fracture and endocarditis are the 2 big concerns with these things. So then the question is, so who should I refer for a PVR? I mean, is there an indication? Yeah. So these are the general criteria which we use. I mean, there are a lot of people that come up with a lot of numbers, but generally, if there's significant pulmonary regurgitant fraction greater than 35% on MR, then that is an indication probably to consider referral for pulmonary valve replacement. Or if you have progressive RV dilatation and dysfunction, that could be another thing. And one of the increasing things we are looking at now is the RV-LV ratio rather than the absolute numbers, because we do know sometimes if you have there is a big series being prepared by one of our fellows, Sarah Blissett, looking at restrictive right ventricles in these patients. What happens is these patients are severe PR, they have evidence of heart failure, exercise intolerance, but the right ventricle doesn't dilate because essentially you have a restricted right ventricle. And I still used to remember in the Brompton, Derek Gibson, who's there when we used to present all this data, used to laugh and say, well, you guys have no idea. You look at the JVP and you look at the echo. Who needs, all these fancy tests? That's what is used to be his comment. But of course, we have all the fancy tests now, and we can prove restricted right ventricular function, does exist, and, it's a cohort of patients. So that's why we look at the RV-LV end diastolic ratio. If it's greater than 1.5 in patients with symptom, that's an indication for referral. Whereas the RV end diastolic ratio is greater than 2, then almost certainly we would definitely say they need a pulmonary valve replaced. This was Tal Jeeva's numbers, from Boston, where they looked at RV and diastolic volume index of more than 160 or Z-score greater than 5. I mean, we brought this cutoff value down to now about 140, and some centers are even going for 120. So essentially, even at early stages of right ventricular dilatation, part of the reason is because, you don't need a 4th redo surgery now. You can do a transcatheter procedure, and virtually every single transcatheter patient, I did one through the neck last week, they all go home the following morning. Very rarely they stay in hospital for more than a day, and within a week they are back to normal. So unlike the olden days where your threshold was higher because surgery was a major limiting condition, it is not anymore in most cases. and press of other hemodynamically significant lesions. The other thing which I should also, RV, outflow tract aneurysm is one. The one thing which I should also add is significant arrhythmias. That is another reason why we, repeatedly refer people now, if any even non-sustained ventricular tachycardia or sustained ventricular tachycardia needing ablation, etc., are conditions where we use. So this is a case example I will try and show, assuming this will play. Okay, so I'm sorry, but so essentially what we are doing is we are doing a balloon testing here, of the RVOT. I'm sorry, I don't know why this video won't play. I checked it 3 times. Sorry. Anyway, so we're doing a balloon testing of this here, and then as you can see, we're deploying a pre-stent, a valve to fix it, and then this is a stent, which goes inside it, and then the valve is deployed, and as you can see, that's the end result with no leakage and excellent positioning, and the patient goes on the following day. In this case, the patient had a problem with the IVC, so we couldn't do it through the IVC, so we had to go through the neck, the jugular vein, and this is a 24 French sheath in the internal jugular, which we can manage without any problem, and the patient still goes home the following day. So this is a patient, thank God, this one does play. So this is a patient with a valve in valve. This is a previous valve put in a the pulmonic position. This is a Carpentier-Edwards valve, which has been there, and then what we've gone is, we've gone and deployed this valve here, and shows the excellent result, as you can see. So do these things work? Because that's the question I always get asked. Does this work? Transcatheter is a great option. It's not as good as surgery. Actually, this is the biggest series, which I was lucky enough to co-author with some of really some of the bright and the best in congenital heart disease in Europe and Canada. So nearly 845 patients undergoing transcatheter pulmonary valve implants. And as you can see, the cumulative, incidence plots for composite endpoint, free is up to 5 years. It's pretty low. Beyond that, what you do get is, it's driven by either need for repeat surgery for other conditions, et cetera, et cetera. But still, the outcomes, as you can see, are pretty good and excellent in the short and medium term. This is a summary slide because one of the questions which is always asked is, what is the risk of endocarditis with these? There is about a 2% per year risk of endocarditis with these patients. So again, when you see them in clinic, advice for good gentle hygiene, avoidance of body piercing, avoidance of tattoos, all these things are advice we constantly give these patients because transcatheter valve endocarditis is a bad thing. Whenever it happens, patients don't do that well. They need emergency heart surgery, and it's not something which is pleasant either for the patient or the physician. One of the other things we also learned is not to leave too much stenosis because we did realize that for every 5 millimeters of mercury, higher you leave, the composite endpoint, risk increased, and also the risk of endocarditis increased. So now we would never let anyone leave the cath lab after transcatheter implant with more than a 10 millimeter gradient across the pulmonic valve. We'd ensure it is somewhere 10 or lesser to ensure, the risk of previously it used to be 20, but now, this is something we've learned. This is the US series, which is a smaller series, which is published by John Cheatham and Co. 2-3 years ago. As you can see, again, excellent survival benefit, and explant is very low. Reintervention rates, again, at 6 years were very low. So essentially, this is a procedure which works pretty well. And as a comparator, these are a lot of surgical pulmonary valve replacement series are there. And as you can see, the rates are not very dissimilar. There is an attrition rate of around 6, 7, 8%, for various things. One of the other things, we need to look at tetralogy fellow. Late VT is very common. So generally, anyone who's a repaired TET who's presenting for first time, they've not had a Holter monitor or a Zia patch or whatever you fancy should get one. And, in this series, nearly about 45% of patients had complex ectopy or VT. Non-sustained VT is very common. And sudden death, it's around 6%. In the long term, 4.5% per 100 patient years. It's not super high, but at least I've seen in my 18-year career in congenital heart disease, two young females, in their 40s, dropped dead despite, all the best precautions in the planet and giving advice because, they were against having an ICD. They said, well, it's not something we want to consider. So I think it's something one has to be careful about and counsel them very carefully, why we need to consider this. So this was, when is VT dangerous? We would generally say if anyone who has a QRS duration of more than 180, VT is dangerous, and if it is sustained VT, it's dangerous. And guess what was the biggest predictor of, sustained VT or sudden death? It is pulmonary regurgitation. So we now do know that there's no point, in doing 5 VT ablations or putting an ICD if you don't fix the underlying hemodynamic. So good, do the ablation if need be, but, fix the hemodynamic. That's what we do now for any referrals we get, and then, they get an ICD later on if needs be. So this is points to remember for this one. RVOT dysfunction with pulmonary regurgitation, stroke stenosis is common in these patients, often asymptomatic, and so refer to a specialist center if you have concerns. And ventricular tachycardia can cause sudden cardiac death even in these patients. I'll move on to transposition of great vessels. This is a more common condition, and without intervention, long-term survival is possible. It's not possible. Any kid who's born with a transposition, i.e., your pulmonary artery comes off the morphological left ventricle, and your aorta comes off the morphological right ventricle. And the commonest procedure was called the atrial switch procedure, the mustard or the Senning procedure, and the other one was a Rastelli procedure. But both of these are not used anymore, except in very rare situations. The procedure which mostly uses arterial switch using the Lecomte maneuver, where the surgeon pulls the aorta and puts it back into the left ventricle and puts the pulmonary artery back into the right ventricle. So essentially, you have normal restoration of circulation. But that comes with its own problems. So the early ones all had significant pulmonary RVOT outflow obstruction because the surgeons did not mobilize the vessels enough, and also the other problem is coronary occlusions can happen. Left main lesions can happen in these patients, although with increasing experience they become lesser. So as you can see, this is the morphological right ventricle gives off the aorta, and the morphological left ventricle gives off the pulmonary artery. So the commonest problems most of these patients are now in the 40s and some even in the 50s. Brady and tachyarrhythmias are extremely common in this population group. Systemic right ventricular function failure is common, and the systemic AV valve, the tricuspid valve in this situation, systemic AV valve. So regurgitation of this is quite common, but if it's very severe, then it needs attention. But a lot of them have mild leaks which are fine. So there are any number of complications which can happen, baffle stenosis. In fact, we got 2 patients scheduled for baffle stenting in the next month, with significant SVC pathway obstruction. So these are all, and then there was atrial tachycardia and various other things, which happened. This was looking at the difference between the mustard and the Senning operation. The mustard uses a Dacron patch, whereas the Senning uses the patient's own pericardium to baffle them. So this is a case of a baffle leak, which we often close. There is already a device in there, but as you can see, there's a lot of contrast going into the left atrial chamber here, and then, we put a second device, and, it is now sealed. It just fills the appendage. And so these are all simple interventions, and, patients can go home the following day, and essentially what you have is, increase in saturations. So the arterial switch operations, the things to look for: pulmonary artery RV outflow stenosis, coronary stenosis can occur, although incidence is very low. Aortic root dilatation is very common. We don't know why, but almost always, what we are seeing is these patients seem to have a bigger aortic root on CT scan and MR scan. Dissections in these roots are uncommon, but nevertheless, if there is progressive dilatation, certainly recommend considering root replacement if that to happen. The good thing about this operation is left ventricular systolic function is usually preserved. So if someone has had arterial switch, they got a bad left ventricle, always look for another cause or something's not right, because LV function shouldn't be compromised in these patients. So I'll move on to this rapidly. Arrhythmias in congenital patients. Loss of sinus rhythm is the commonest cause of hospital admission. This is not an uncommon. Ask any ECG fellow, they'll tell you God. And 39% is the commonest cause of sudden cardiac death in kids with congenital heart disease, and is the commonest cause of emergency admission post-op, adult congenital patients. So this is something which, almost all of us will see in your lifetime at some point or the other as practicing cardiologists. Can be difficult to detect, whether it's atrial re-entry tachycardia or sinus tachycardia, can be difficult because the ECGs are almost always intrinsically abnormal, often multiple and recurrent, and significant morbidity resistant to drug therapy, because usually most of these patients have been tried on 4 different drugs, by the EP docs, and nothing has worked very well. They've had 2 different ablations. So lifestyle impact, is a big issue with these. And one of the commonest things which we see is atrial flutter with 1-to-1 conduction, which can be as bad as VT in young patients, because if you have a flutter at 180 and you're conducting at 180, you can decompensate pretty fast. So in transposition of great arteries, the arrhythmia-free survival, I won't bother too much on this. I'll move on. Bradyarrhythmias are common in patients with DTGA and congenitally corrected transposition, around 1 to 2% per year loss of sinus rhythm. So you can imagine, by the time they get to 50, about 50% of them will end up needing a pacemaker, so it's a pretty common problem. In patients with uncorrected AVST, example, older Down syndrome patients, again, an issue. And as you can see, anatomically, it makes sense because the atrioventricular septal defect, is in a position where the AV node is. So essentially, intrinsically, the AV node is not normal. So, leading to heart block is pretty uncommon. And loss of AV synchrony in patients with tricuspid regurg may worsen function. So we'll just move on quickly to the Fontan circulation. This is the dreaded word. I mean, you say this, it's enough to put off any cardiologist or anyone else who's saying, oh, God, it's a Fontan, I'm going to run a mile. But actually, it's pretty simple. It's nothing but a direct connection of systemic venous circulation to the pulmonary arteries. You don't have a right ventricle to pump or a morphological right ventricle to pump. What you have is the atrial blood, the IVC blood, the caval blood, SVC and IVC, is directly taken into the pulmonary artery. Of course, there's a surgical conduit, we just made. It's often used in patients with tricuspid atresia because they usually have a hypoplastic small right ventricle. It's previously used, the RA, when Fontan, who was a French surgeon, originally devised this operation. He passed away actually a couple of years ago. He was very clever. He used the right atrium as the pumping chamber, and this was a super clever idea at that time because it used to work very well until they were about 2025. It worked fantastically well, but now we know it's not a great operation simply because your right atrium keeps on dilating and dilating and dilating and causes heart failure. It causes arrhythmias, so it's a bad operation, from that point of view. So now what most patients get is something called a totocavopulmonary anastomosis, i.e. the SVC is plumbed into the RPA, which is called a Glenn shunt. And previously they used to tie off one end of the RPA, communicate in the LPA, but now we know that's a bad idea. So it's just connected, end to side with the right pulmonary artery, and the IVC is connected to the PA either via a cardiac or an extracardiac conduit, and essentially, that helps blood return to the heart. Arrhythmias are very common. This is a case of a 26-year-old female with tricuspid atresia, RAPA Fontan, feeling generally unwell. Oh, I'm feeling a little bit lousy, I'm not too bad. And then you look at her, this is what she has. She's running at a rate of flutter with a rate of, around 200. So often young patients can be deceiving. They can have pretty fast heart rates without much symptoms. So what we did was, this was prolonged, sinus node reentry tachycardia. So this is what she had. So she ended up having an ablation and then having a atrial single-chamber pacemaker. Actually, in her case, the AV node conduction was very good. And when she came back to clinic, as you can see, atrial sense V sense was 2.6%, and her atrial sense V pace was less than 0.1%. And she was pretty much atrial pace V sense. So that is what we want because it keeps your QRS narrow, and it's physiological. So it's kind of horses for courses, and try and keep a physiological rhythm as best as possible. So arrhythmia management is important to understand the anatomy. Chemical cardioversion, is tough in these patients because you think of amio, usually they've been on amio 200, 400, you name the dose. So kind of, giving more amio is unlikely. If you're trying to cardiovert a Fontan, have a plan for emergency pacing because sometimes you have atrial flutter, you go and shock them. They almost all have sinus node disease because, the right atrium is enlarged. So you shock them, sometimes they don't have a rhythm, it's a flat line. Then if you try and think you're going to get a temporary wire, there's nowhere to put a temporary wire because there is no right ventricle. So if you hit the femoral vein, it's going to take you straight into the PA. So we're going to pace them. So if you want to really pace them, the only way is either external or you put a femoral arterial line and cross the aortic valve and pace the left ventricle. I've done that twice in my life. It's not a particularly pleasant experience, but that's the only way to tide them over temporarily till you can get other support. Systemic ventricular function may be poor, so giving them these class 1 agents is not necessarily a great idea. We'll just move on quickly to aortic coarctation. Always suspect when hypertension is diagnosed in young adults, and people always think of renal artery stenosis, et cetera, but this is one condition where you should think whether it is something, which you can help with. Radiofemoral delay is only seen in severe cases, so don't get fooled by it. It is classically beautifully described. MR or contrast CT is the best investigation for assessing these patients. The left radial pulse may be weak if there's a previous subclavian patch repair which is done, but most repairs these days which are done into an anastomosis. Recoarctation is not uncommon in adults. And I'm sorry, this video again doesn't play, which is too bad. So what we do is, I don't know if I can pick this up. Just give me 1 second. I know I have this stored here. I just thought this is a very... Yeah, I'm just saying if I could show it to them. This is a really good picture to see, but... Sorry about this, but I just thought, this would be a good one for you. This is a really cool picture, and as they say, so why doesn't play? Nothing comes up. Why is that? It's got a problem. It's playing in my computer.
Just drag it to the other side.
Okay, great. I didn't realize that was an issue too. Okay, thanks. So as you can see, that's a super tight coarctation. I mean, for those of you, I mean, if you can look at it, that the big vessel you see there is the internal mammary, which comes, fills. It's bigger than the femoral artery, and this is the coarctation here. I mean, that's about 2 millimeters in diameter, near total interruption of the arch. And what we can do for this is, now we can put a covered stent and treat these, and which is what we did in this case. I will show you the final result, if I can. Why is this not playing?
You'll have to drag it all the way to the other side, right here.
Okay, so that's how we treated with the primary covered stent. And as you can see, full patency is restored. This had a gradient of more than 80 millimeters of mercury across the coarct, and the patient left the hospital, 24 hours later with virtually no gradient across the coarct. So these are all things which we can do. And I'll just quickly show the pulmonic case, which we did as well previously. As you can see, severe. You had to take this here too.
Right.
Okay, and then I can't play this here. I lost my mouse. Okay. So as you can see, this is where we have, this is a case which I was going to show you earlier on, severe pulmonary regurgitation. Someone has had 3 previous surgeries. And see how the pulmonary artery is stuck to the retrosternum. So there is no way the surgeon can realistically, open the heart without, open the chest wall without cutting through the heart. So what we do in these cases is, do a transcatheter option, and I will show you the end result with this procedure just for reasons of time. If you can find it, okay.
It's right there. It's on the other side.
Oh, it has come here.
Yeah, but it just dropped as a small.
Okay, it went too far. Okay, that's it. I don't know if you can play that, but if you can't play it, don't worry, it's fine.
Is it this one? Is it this one?
Yeah, that one. Yeah. So that is the end result, as you can see. And, there is a, it doesn't play for some reason. I don't know why, it's lost everything. That's it. So as you can see, that's the end result. There's just tiny leak which you see through the wire, and full patency, full function of the pulmonic valve is restored. So, great. I'll just go back to my talk and try and get through the rest of the slides. So how do I go back?
Minimize?
Yeah, it's here, yeah. Yeah, great, thank you. So how to manage an aortic coarctation?
Let's go here.
Sorry, I had to go to this one here. This one?
Yeah.
Yeah. So how to manage a coarctation? About 40% of coarct patients have a bicuspid aortic valve. And so that is something, very important to assess, with an echo. Rule out a cerebral aneurysm, and about 10% of them have it. We generally don't routinely screen for this, but if you do have a suspicion or someone has had a small bleed, and the one situation we do screen is if they are going to need Eliquis or Coumadin, then we usually do a MR scan to ensure they don't have an underlying aneurysm, because then the risk of a cerebral bleed is higher. And if there is a bicuspid aortic valve, make sure there's no significant stenosis. And one of the syndromes which is associated with coarctation is Turner syndrome. So whenever you see a patient who's got short stature with, features such as of Turner's and they have hypertension, always make sure you get an MR scan to ensure they don't have a coarct. So treatment stenting is the option, as they said. Surgery may be required as a large aneurysm, although we just recently presented in TCT a 10-centimeter aneurysm, from a previous coarct repair, which we treated with a stent graft and coils. So it is possible. It can be treated in patients who are not suitable for surgery. We advise surveillance with MR or CT once every 3 to 5 years. I'll just quickly go through the ASDs, which is the commonest congenital defect. Atrial arrhythmias, atrial fibrillation can be the initial presentation in adults, which is unrepaired. You do see this commonly in the immigrant population. We almost close an ASD every other week, in recent immigrants who have not been diagnosed in childhood and present either with atrial arrhythmias or some degree of right heart failure or symptoms. So we usually do a TEE to confirm and look at the rims. So, and also the couple of things to consider in ASD, if the right heart enlargement looks out of proportion, for example, they have 1 centimeter ASD and the right heart is, looks super super big, always think of an anomalous pulmonary vein. So do a CT scan. That is something we always recommend. The percutaneous closure is the first line of treatment. The largest available device in the United States is 38 millimeters. So we should, close most defects if possible. One of the big things which you have now started upon is a treat and close. We have seen quite a few young patients with significant pulmonary hypertension who in the past would have said just give therapy, don't close it. But now we have a very active program, which I run along with the pulmonary hypertension folk, of putting them on triple therapy, i.e. in a PDI5 like sildenafil or tadalafil, macitentan, and Uptravi. If the Uptravi alone is not enough, we switch them to IVs or orals. We've had a fantastic case where there was a 28-year-old female who had a previous kid, came with near systemic pressures with reversal of shunt. On triple therapy, PVR fell to normal. We went and closed the defect, and now we've wound off all the pulmonary hypertension. She was on a small dose of sildenafil, but she's planning to have another child, so we've stopped that too. So essentially that is possible. And we've had success with a couple of PDA patients, a couple of VSD patients. So now with all the new drugs in the pulmonary hypertension armamentarium, that is something you can treat. But this is a long process. We tell them there's not going to be one day affair. You come to my clinic, I'm going to give you a pill. They got to be signed up to a process which lasts about 18 to 24 months because you need at least 3 or 4 right heart caths, serial assessment of your RV pressure drop and your PVR drop before you can have definitive therapy. So atrial arrhythmias, again, are not uncommon. Atrial flutter fibrillation is the commonest. There is a big case to be made, even relatively asymptomatic ASTs, to get them close before they're less than 40, because the risk of atrial arrhythmias becomes lesser. And short-term, 2/3 of patients with paroxysmal atrial fibrillation will improve. And we used to actively advise, PVIs before ASD closure. I kind of gone off that now, because all it does is it makes the patient wait for another 3 months and delay things. So if you do get, atrial fibrillation after that, it can be dealt with, either by cardioversion or by whatever mechanisms. And now we can, puncture through the septum with a lot of, smaller devices. That's not impossible either. So in congenital heart disease, this is the golden rule. So infective endocarditis is, again, about 4% of all admissions to another congenital unit. You get all kinds of unusual organisms, streptococcal, enterococcal, HHAC. We've currently got at least 2 patients sitting in there with endocarditis. The lower risk ones are in the top, and the higher risk ones are the Fontans and, the unoperated bicuspid valves, et cetera, et cetera. Again, heart failure in this population subset is very common, as I told you. Unfortunately, if you have a systemic right ventricle, there is no great evidence so far. There have been multiple studies done for either an ACE inhibitor or an ARB. We do give it to these patients. And actually, in Fontan patients, I think this is a disservice, because essentially what they do is when you have a Fontan circulation, you're very much dependent on your preload to take blood to the heart. And essentially, if you give an ACE or an ARB, essentially what you're doing is you're dropping the preload and causing, venodilatation along with arterial dilatation, and essentially your SVR becomes lower, and so essentially the forward flow becomes lesser. So I personally, don't recommend, giving these to these patients unless they have severe systemic AV valve regurg, which is one condition we consider. Pulmonary embolism and hemoptysis, a high index of suspicion in Fontan type of patients. No point doing VQ scans; they're of no use. Do a CT pulmonary angiogram, which is what we can say. Eisenmenger patient hemoptysis can be difficult to manage. We have done some emergency coilings for these patients to occlude bronchopulmonary collaterals, and that can be life-saving sometimes. Otherwise, these patients can just bleed literally in front of your eyes to death, bringing up 1 and 2 liters of blood with every cough. Cyanotic heart disease, Eisenmenger syndrome, is the most commonest now, commonly associated with unrepaired VSDs or other types of shunt. Epstein's anomaly, which very severe, can cause cyanosis due to poor forward flow. They usually have a large PFO and right-sided failure, and it is because of right to left shunt and cyanosis. And then there are a lot of other, complex conditions like pulmonary atresia, et cetera, occasionally see in adults. General principles: do not perform a venesection. This is something we stopped doing in the congenital world. They have a hemoglobin of 18. There's a good reason they have a hemoglobin of 18, because their saturation runs at 88 or 85 all the time. And we do know if you venesect them, they become iron deficient and increase the risk for stroke. So unless they have super high symptoms of hyperviscosity, like chronic headaches, chronic stasis edema, et cetera, we generally don't advise venesection for patients. And low threshold rule pulmonary embolus, as I said. If sudden bursting of cyanosis, acute occlusion of shunts, if someone is interested, you can come to me. I can show you about half a dozen examples of where, we had patients suddenly go off. The saturation was 80 until yesterday, 60 today, without any good reason. And you go there, a pulmonary artery shunt is occluded, and then we can go and stent it open, and then they feel a lot better. Always use bubble traps for infusion patients with shunts, because I've seen so many unnecessary strokes arise because, people have been careless in connecting drips, and all you need is 2 or 3 air emboli to go into a vein, and they got a big shunt in the heart. The next thing they realize, they have a stroke, and it's a totally avoidable, complication. and avoid systemic vasodilators, and if need be, seek specialist advice. This is a very interesting photo from the International Space Station where, how an astronaut is virtually hanging with one hand, held onto a bar and nothing else. And sometimes treating these patients feels like this, because you don't have much to hold on. They're very fragile, and probably the patients feel the same about themselves too, that. So I think it's a matter of building trust and, working with them together and, achieving the best outcome for these patients. And thanks for inviting me again. Sorry I had to rush through it a bit in the end, but.
Well, thanks so much for that great talk. I personally am very thankful for people like you.
No, John, thank you.
To take care of these very difficult patients because they're so complicated and so challenging. I guess the question is, people with complex congenital heart conditions that make it to adulthood, why not put defibrillators in all of them? Because so many of them die from arrhythmias and it's so unpredictable sometimes.
That's a very good question, but I mean, part of the problem is, the morbidity, associated with defibrillators. I mean, I think in the short term, it's probably pretty low, but in the longer term, putting defibrillators on 20-year-olds and 30-year-olds, to have it for 30 or 40 odd years, the number of generator changes and the lead fractures, and the risk of endocarditis is not so small. And also, I've seen so much tricuspid regurgitation now since we are doing a lot of tricuspid clips and off-label, of course, for all this. And I mean, we just did a tricuspid clip on a 23-year-old, congenital patient, which is the youngest, I think, which has ever been done. And one thing I'm realizing is, the lesser you instrument the tricuspid valve across, probably the better. And because a lot of these are either caused by leads or other things, which are stuck onto them, creating another problem. So while I think it's a very valid question, I think that's part of the reason why, people have shied away from implanting defibrillators more widely. Yeah, that is an option, but unfortunately, they are never quite as effective as the transvenous leads, as you know. And again, the generator changes are even more, required for them because the generator need, battery usage is much higher. What we need is a leadless implantable defibrillator, which will come and, you screw it in, and for 7 years, it's going to take care of it. Then you can explant it and put a new one in. I don't think we're quite there as yet, but. Heart and lung transplant is definitely an option, but the number of heart lungs done, even through the United States is a pretty small number. As you can see, a heart-lung block is difficult to get. And unfortunately, there is a lot of element of gaming in this because every institution, want to keep the transplant numbers high. So they find it much easier to give the 2 lungs to one patient and give a heart to another patient. And then there are cystics and various others. Sometimes they even give 1 lung, so you can have 3 patients get a transplant rather than 1. So that is part of the reason why it is not fair on the patients who need a heart-lung. But the number of heart lungs done are pretty small. One of the other things which has been proposed in that area is to give a double lung and repair the heart. We've kind of done it in one case, where the lesion was a relatively simple lesion like an ASD, and the right ventricle was still functioning well. But usually, the lung transplant surgeons are resistant to it because it's going to prolong our pump times. You need another heart surgeon to come here, fix the hole, et cetera, et cetera. So it comes with its own logistic problems. But a heart-lung block is good. But as you know, heart-lung block survival rates are not quite as high as hearts alone.
Great.
Thank you. Thank you.